السلام عليكم.
وعليكم السلام.
الصوت واضح دكتورة؟
الصوت واضح.
صافي ولا فيه شوشرة؟
لا واضح صافي.
ممتاز، شكرا.
نعم. Assalamu alaikum. Good evening, everyone. This is Inas al-Muhammadi. First of all, I would like to thank you all for your attending. Your presence is much appreciated. I hope you find this course is an informative course. Please welcome with me our first speaker for today, Dr. Abdurrahman Al-Ainazi. Dr. Abdurrahman Al-Ainazi, BGY2 in Hematology, Oncology, Pharmacy Resident in King Abdulaziz Medical City. Dr. Abdurrahman will talk about the chemotherapy-induced nausea and vomiting. Please welcome us, Dr. Abdurrahman. Assalamu alaikum. You hear me well? Okay, thank you. So first of all, I would like to thank you all for your presence. Your presence is much appreciated. Please welcome with me our first speaker for today, Dr. Abdurrahman Al-Ainazi. Dr. Abdurrahman is BGY2 in Hematology, Oncology, Pharmacy Resident in King Abdulaziz Medical City. He will talk about chemotherapy-induced nausea and vomiting. Welcome, Dr. Abdurrahman, so you can start.
السلام عليكم. دكتور ايناس صوت واضح؟
واضح دكتور، تقدر تبدأ.
طيب, thank you Dr. Inas for your nice introduction. First of all, I would like to thank all of the attendants and the organization committee for this nice course. Inshallah, I'm gonna present the chemotherapy-induced nausea vomiting. This is the outline. The objective is to briefly review the impact of chemotherapy-induced nausea vomiting of hematology oncology patients, and also to briefly review classification of chemotherapy-induced nausea vomiting, also mechanism, risk factor, and the emetogenic potential of different anti-cancer agents, and also to discuss the major part, which is the pharmacologic option of a prevention and treatment of chemotherapy-induced nausea vomiting, and finally to be familiar with the approach of choosing the anti-emetic for prevention and the treatment of chemotherapy-induced nausea vomiting. So to start, nausea and vomiting are two of the most frequent and troubling side effects that can have significant impact on patient health-related quality of life, which lead to affect the compliance of these patients with their effective chemotherapy regimen. Chemotherapy-induced nausea vomiting also can lead, beside the impact on quality of life, it can lead to dehydration, electrolyte imbalance, weight loss, and malnourishment. All of these can lead to or result in additional office visit or emergency department visit, and even hospitalization. So, the frequency of chemotherapy-induced nausea vomiting reach up to 80% of patients receiving chemotherapy. Moving to the classification, mainly or in general, we have five classification of chemotherapy-induced nausea vomiting. These classification mainly depend on the time of occurrence. So for the acute emesis, usually occur 1 to 2 hours after chemotherapy, and the peak is 5 to 6 hours. For the delayed emesis, it occurs 1 to 5 days after starting chemotherapy, and the peak is 1 to 2 days. For the anticipatory emesis, it usually happen before the patient receiving the next chemotherapy cycle. So in this scenario, patient is receiving a chemotherapy cycle and suffer from bad nausea vomiting. So before starting the next cycle, patient anticipating to have a second attack of nausea vomiting from his experience. So patient will suffer nausea vomiting as anticipatory. So it's before starting the next cycle. For the breakthrough emesis, it usually occurs despite use of the prevention method or prophylactic or rescue therapy. And for refractory emesis, which occur after using the guideline-directed prophylactic anti-emetic agent. And all these agents have failed in the this classification. Moving to the pathophysiology, although there are over or more than 30 neurotransmitters have been associated with the peripheral and central nervous system sites involved in chemotherapy-induced nausea and vomiting. But however, three neurotransmitters have the most clinical relevance, and these are dopamine, 5-hydroxytryptamine, and substance P. So our anti-emetic usually targeting one of these neurotransmitter. For nowadays or the current knowledge, it suggests that the anti-emetic response to chemotherapy can occur through a central and a peripheral pathway, and it depends on the site of the triggered receptor. So for the peripheral pathway, which is predominantly mediated by the 5-hydroxytryptamine and 5-hydroxytryptamine 3 receptor, usually it is in the intestinal tract, and it is associated with the acute type emesis. Whereas the central pathway, which predominantly mediated by substance B and neurokinin receptor, and it is located in the brain or in the brainstem, and it is responsible for the delayed type of chemotherapy, nausea and vomiting. This picture, in this picture, you can see here that the chemotherapy patient, while when patient received chemotherapy, it will trigger two areas. This is the peripheral pathway, which trigger the intestinal site. It has a 5-hydroxytryptamine receptor or serotonin receptor. It is triggered by or stimulated by the chemotherapy, which will send stimuli to the or the brainstem, which this or will induce or send another signal to the stomach to induce emesis. And for the central pathway, usually it is the chemotherapy directly stimulate the neurokinin receptor in the brainstem, and it will lead to another sending another signal to the stomach to induce emesis. Moving to risk factor, usually risk factor for nausea vomiting depend on patient. So patient with higher age has higher potency for nausea vomiting. Female has higher risk factor. Patient with history of emesis or motion sickness, or patient with experience of a previous chemotherapy induced nausea vomiting. And also patient non-alcohol user has higher risk of emesis. For the type of cancer, usually GI and brain cancer has higher risk of emesis. And for the chemotherapy, it depends on the emetogenicity risk of a single agent, the dose, frequency used in as a single or in combination. So the emetogenic potential of anti-cancer agent classified mainly to 4 parts, and this classification usually depend or based on the frequency of emesis that induced by this chemotherapy. Highly emetic risk anti-cancer agent usually have a frequency of emesis more than 90%, whereas Moderate emetic risk has a potential or frequency of 30 to 90% of emesis, and anti-cancer agent with low emetic risk induce a frequency has a frequency of emesis between 10 to 30%, and finally minimal emetic risk anti-cancer has less than 10% frequency of emesis. It is very important to know this classification since the treatment or preventive method mainly depend on this classification. So let's take a look for the emetogenic potential for the intravenous agent, and this table adapted from the NCCN. Let's just take an example for high-level anti-emetic. All of you have to know that cisplatin, regardless to the dose, regardless it used as a single or combination, consider a highly emetogenic anti-cancer agent. Whereas, for example, doxorubicin here, when it used in a dose more than 60 milligram per meter squared, considered as highly emetogenic. And when it is used in a dose less than 60 milligram per meter squared, considered as a moderate emetogenic. This is as a single. However, when it is used in a combination with cyclophosphamide, regardless to the dose of doxorubicin, it is considered highly emetogenic. So it's better to be familiar with this table. You can find it in the NCCN, or even you can find it in another guidelines such as ASCO or ISMO. This is for low and minimal. Usually low and minimal include a single agent anti-cancer. This is for intravenous. For oral agent, moderate to high emetogenic agent potential, usually including the targeted therapy such as olaparib and also crizotinib. And for minimum to low, also including either a cytotoxic or targeted therapy as a single agent. This is for the oral agent. Moving to the major part of this presentation, which is prevention and the treatment of chemotherapy-induced nausea vomiting. The goal of therapy is to prevent nausea and vomiting, and also treating nausea and vomiting in breakthrough and refractory cases, and also to improve the patient compliance to the offending agent, which is the anti-cancer, and lastly, to improve the quality of life of these patients. So prevention is the main goal here. Before starting anti-emetic, there is some consideration we have to consider it. We have to consider other causes of nausea and emesis in patient receiving chemotherapy, such as patient is receiving another non-anti-cancer agent that induce nausea vomiting, patient receiving radiotherapy, and any other cause that induce nausea vomiting. Also, we have to evaluate risk factor for when choosing a chemotherapy regimen, the risk factor of emesis, such as cisplatin. We know cisplatin, the most common anti-cancer that induce nausea vomiting, and it is the nausea vomiting is dose-limiting toxicity for cisplatin. For multi-drug regimen, anti-emetic prophylaxis based on the drug with highest emetic risk. For example, patient receiving combination chemotherapy, and these combination include two anti-cancer. One of them has a high emetogenic and the other one has low or minimum. When we are considering anti-emetic prophylaxis, we will go with the drug with the highest emetic risk. Also, it is important to consider H2 blocker and PPI to prevent dyspepsia, which can mimic nausea, and also the anti-emetic by themselves can induce dyspepsia, such as a steroid. Also, it is very important to consider non-pharmacologic measures or non-pharmacologic options before starting pharmacologic option, such as small, frequent bland meals, maintaining hydration, eat food at room temperature, avoid greasy, spicy, and salty foods, which will aggravate nausea and vomiting. This is the anti-emetic option that we have. In the left side, this group usually used for prevention of acute and delayed, and the group on the right usually for breakthrough and refractory cases. Uh, Steroid, either dexa, methyl, or prednisolone, serotonin receptor antagonist, including granisetron, ondansetron, and palonsetron, which is the newer agent or second generation. Neurokinin receptor antagonist, including aprepitant or fosaprepitant and rolapitant. And also we have Akinzio, which is a newer combination between serotonin receptor antagonist and neurokinin receptor antagonist, newtipitant plus palonsetron, which has a very long half-life and efficacy. Olanzapine. Also, we have substituted benzamides such as metoclopramide. Also, benzodiazepine is an option, antihistamine or anticholinergic, phenothiazine, and also haloperidol, and finally cannabinoids. Let's start with some pharmacological and clinical consideration for this anti-emetic. I focused on the major part that we are gonna use. For steroid, it is very important to consider this. Use steroid as anti-emetic is not recommended with immunotherapy and cellular therapy. So patient going to receive CAR T cell, or patient is going to receive immune checkpoint inhibitor, and using steroid is as an anti-emetic to prevent nausea, vomiting from this modality of anti-cancer is not recommended, since it will antagonize the effect of this anti-cancer agent. And also caution in patient with diabetes mellitus, and it may induce dyspepsia. Also, it's important to consider that in chemotherapy protocol that containing steroid, you can modify or omit the original. You can modify or omit the anti-emetic steroid and use the original steroid in the original chemotherapy. For example, patient going to receive R-CHOP chemotherapy protocol, and it contain steroid, so no need to giving a full dose of dexamethasone as an anti-emetic. You can use the prednisone in that protocol as both anti-emetic and anti-cancer. For patients suffering from extended or delayed chemotherapy, nausea, vomiting, you can consider extending the course of delayed dexamethasone as appropriate. Moving to serotonin receptor antagonist, the most important thing here is the adverse event and drug interaction of serotonin receptor antagonist. It has dose-dependent QTc prolongation, and it can induce constipation. And also, when verifying a prescription or reviewing a patient medication profile for patient receiving serotonin receptor antagonist, always consider drug interaction with a drug that prolong QTc. For the route of administration, oral and parenteral is equivalent in efficacy. Serotonin receptor antagonist, best effect seen when given as a scheduled administration, not as a PRN, and it is usually recommended for acute nausea and vomiting, for prevention only. For the neurokinin receptor antagonist, the most common adverse event is asthenia, dizziness, and hiccups. Also, it has drug interaction with where it induce and also inhibit cytochrome P3A4, and also it is a strong inducer of cytochrome P2C9. Exception for rolapitant, which has no effect on cytochrome 3A4. As an example of substrate for cytochrome P3A4, we have dexamethasone. So now we're going to use dexamethasone with neurokinin receptor antagonist, such as aprepitant, where they are interacting between each other. So you have to consider this interaction, and also it is a strong inducer of cytochrome P2C9. So patient on warfarin, for example, going to receive a neurokinin receptor antagonist, you have to consider more frequent INR monitoring. For the rolabitant, anaphylaxis and anaphylactic shock and serious hypersensitivity have been reported in the post-marketing setting. Also, for the same medication, it has very long half-life and the frequency should not be less than 2 weeks. The neurokinin receptor antagonist indicated for prevention of chemotherapy nausea vomiting, not for treatment of a breakthrough, and largest benefit seen with delayed chemotherapy-induced nausea vomiting. So serotonin receptor antagonist for the acute and neurokinin receptor antagonist seen to be or the largest benefit seen with the delayed. Olanzapine is a typical antipsychotic, and it has been used for prevention of highly emetogenic regimen, and it's also used for treatment of breakthrough chemotherapy-induced nausea vomiting. The problem of olanzapine that it has many adverse events, including postural hypotension, QTc prolongation, sedation, and dizziness. And it's usually suggested as an alternative to neurokinin receptor antagonist for delayed nausea and vomiting. It is effective as a rescue agent for breakthrough, which has a big advantage over the others. It's important to consider to administer olanzapine at bedtime due to the sedative effect of this medication. Moving to the atypical antipsychotic and phenothiazine, metoclopramide, haloperidol, all the dopaminergic antagonists. It may increase the risk of a QTc prolongation. You have to monitor for drug-induced drug interaction with the drug-induced QTc, and metoclopramide has an advantage as it shows a benefit in patients with the gastroparesis. For benzodiazepine, it is a causing CNS depression. It's usually considered for the anticipatory chemotherapy-induced nausea vomiting or for breakthrough. It is not used for prevention of chemotherapy-induced nausea vomiting. And also a caution should be taken in patients receiving opioids since it will increase the risk of respiratory depression. So for now, moving to what is the approach or how to prevent or how to write a management plan for the prevention of acute and delayed chemotherapy-induced nausea vomiting. The approach of management is similar across all guidelines, ASCO, NCCN, ISMO. Usually there is no big difference between these guidelines. For highly emetic risk, 3-drug regimen has been the standard of care. And sometimes, and it's for the acute, we are using neurokinin receptor antagonist, serotonin antagonist, and steroid. Also, olanzapine can be added as a fourth option to add on this backbone therapy. For the delayed anti-emesis, we gonna use steroid plus minus olanzapine and plus minus neurokinin receptor antagonist. For moderate emetic risk, 2-drug regimen can be used. And the backbone is for acute serotonin receptor antagonist plus steroid. For the delayed, steroid. For low or minimal emetic risk, single drug can be used, or observation for minimal emetic risk for acute nausea vomiting. For delayed nausea vomiting, prophylactic measures usually not routinely recommended. Let's take an example from ASCO. This table adapted from ASCO guideline for anti-emetic. For highly emetic agent, they recommend the neurokinin receptor antagonist, serotonin antagonist, steroid plus olanzapine for option or for medication. This is the dosing for it should be given on the day of chemotherapy, should be given 1 to 2 hours before chemotherapy. And for the subsequent days of chemotherapy from day 2 to 4, they recommend if we're gonna use a prebitant in the day of chemotherapy, it should be continue for day 2 and 3. And also dexamethasone zone for delayed chemotherapy induced nausea vomiting, and also olanzapine can be added. This is just an example. This is for if anthracycline and cyclophosphamide is the offending agent, it's no need to administer steroid on the subsequent days of chemotherapy. Moving to moderate and low, the same. Now in the moderate, they are using two backbone, which is serotonin receptor antagonist plus Dexa. And for delay, they are going to use Dexa on day 3 and day 2 and day 3. For low emetogenetic potential, no need for delayed anti-emetic. So moving to another type of nausea vomiting, which is anticipatory. Prevention of anticipatory nausea vomiting is the key, and behavioral therapy is an option. Also, prophylactic benzodiazepine can be used before and after chemotherapy to decrease risk of anticipatory chemotherapy-induced nausea vomiting. For the breakthrough and refractory cases, the principle here is to treat, not to prevent. So the principle to give additional anti-emetic from different classes that has not been used in the prevention, and usually 1 or 2 agents with different mechanism of action. And guidelines strongly recommend to use this medication routinely, not as PRN, and they suggest IV or rectal route. An option here is to use dopamine antagonist, metoclopramide plus minus diphenhydramine, phenothiazine, olanzapine if not used in the prevention. Also, steroid can be extended. If it is used in the prevention, it can be extended for the delayed and for the breakthrough. Also, benzodiazepine is an option for breakthrough. So you can see here that serotonin receptor antagonist and the neurokinin is not an option for breakthrough and refractory cases. Moving to last part, which is the role of pharmacist. Yes, a pharmacist has a major role in chemotherapy-induced nausea vomiting. A pharmacist is an essential part in writing and developing institutional guideline, also to develop this guideline and to monitor the adherence of healthcare provider with this guideline. Also, pharmacists help in selection the appropriate regimen based on patient characteristic, and also for monitoring for drug-drug interaction, and also for prevention, monitoring, and detecting toxicity from the anti-emetic. And also pharmacists can improve patient adherence with counseling. And lastly, pharmacists can educate healthcare provider, patient, and patient relative about the pharmacologic and non-pharmacologic measures. Moving to conclusion, chemotherapy-induced nausea vomiting is a major complication of anti-cancer which lead to discontinuation of the effective anti-cancer therapy if not prevented and treated well. Emetogenicity of anti-cancer different between drug to drug. Follow Anti-Emetic International or your institutional guideline as a starting point to start anti-emetic prophylaxis before starting chemotherapy. And last thing, pharmacist has a major role in chemotherapy-induced nausea vomiting. Now, let's move to question. I have 2 questions. This is the first question. You can just take a picture for this barcode to move to the first question. You will find the question and you can answer it. Patient is going to receive cisplatin. What is the best recommended anti-emetic regimen? Dexa plus aprepitant plus Grani, or Dexa with olanzapine, or Dexa plus metoclopramide plus olanzapine. So now 73% participants voted for Dexa plus aprepitant for Grani. and 19 or 20% for 18% for Dixa plus metoclopramide for olanzapine. So the correct answer is dexamethasone plus aprepitant plus granisetron. So metoclopramide is not a part of a prevention; it is a part of treatment of a breakthrough and refractory cases. Moving to the second question, you can take a picture for this barcode to participate in voting. This is the question. What is the following anti-emetic is not indicated for treatment of a breakthrough chemotherapy-induced nausea vomiting? Metoclopramide, granisetron, olanzapine. What is the following anti-emetic is not indicated for treatment of breakthrough? So the correct answer, unfortunately, not metoclopramide. The correct answer is a granisetron. Metoclopramide is indicated for treatment of a breakthrough nausea vomiting, whereas a grani is not indicated. It is for prevention of chemotherapy-induced nausea vomiting. Thank you for participating in the vote. And this is my reference, and there is a reading material if you can use it for more advanced information. And thank you.
Thank you, Dr. Abdulrahman.
Thank you, Master.
So please, if you have any question, please raise your hand or ask the question in the chat.
Thank you all. Thank you all for your attendance and for your attention. I think we have two questions here. Abdulaziz asking, why does anti-cancer drug cause vomiting? Usually it's based on the activation or triggering the neurotransmitter receptor in the intestinal and in the brainstem by the chemotherapy. We have neurokinin receptor in the brainstem and serotonin receptor in the intestine activated by the chemotherapy, which will induce nausea and vomiting. The second question from Muhammad, I wonder if all patients suffer from nausea vomiting after prophylaxis therapy considered to have a breakthrough? Yes. If patient use the optimal anti-emetic prophylactic and patient experienced nausea vomiting while he is on the optimal prophylaxis, it's considered breakthrough. Reference, you can use the NCCN guideline or ASCO guideline for anti-emetic. Yes, Muhammad, and patient with a breakthrough need to be treated. Dr. Inas, I think we are done.
Okay, thank you, Dr. Abdulrahman. Now, please welcome with me our second speaker for today, Dr. Abdullah Zahrani. Dr. Abdullah Zahrani is the RSP Oncology Hematology resident in King Saud University Medical City. He will talk about the febrile neutropenia. Welcome, Dr. Abdullah.
Helen, thank you. Thank you, Dr. Inas, and thank you all for attending. صوت والسلايدز واضحين؟
Clear, Doctor.
Okay. طيب, I will go thoroughly background pathophysiology treatment and prophylaxis. You can find all the details in my slides. I will just touch upon how to think and focus on some of the concepts. So I will start with the neutrophils. Now, the neutrophils belong to a group of white blood cells called the granulocytes, as you know. So we have three types of granulocytes: neutrophil, eosinophil, and basophil. The eosinophil and basophil are mainly concerned with allergic and parasitic infections, and we will focus on neutrophils since they are mainly concerned with fighting bacteria, fungi, and viruses. So neutrophils, we have two main types. We have band and segmented, and this is because of the morphology of the nucleus of the neutrophils. So the band is immature neutrophils that upon maturation, they will transform to the segmented. Now the segmented is the active one. Why this is important is because, as you will see in the case that I will present, in order to assess the neutrophil function, you have to calculate both the band and the segmented. In infectious cases, the band, you will see the band that will rise and eventually will transform to the segmented, which is the active one. Now, this is just a diagram to remind you that the white blood cells, or all the blood cells, synthesis takes part in the bone marrow. So when we say that the chemotherapy is bone marrow toxic or anything related to the bone marrow, you might expect that the white blood cells and the neutrophil eventually will be affected. So how the neutrophil functions? If we have an infection in some tissue, certain changes will occur, and we have the neutrophils that are circulating in the blood. They will sense these changes, then they will infiltrate into the tissue, and then they will kill the bacteria or the fungi through the process of phagocytosis. They will eat the bacteria, and then their special granules will secrete specific antimicrobials that will kill them. Another mechanism is that they secrete cytokines. These cytokines will attract T cells and B cells. Now, the first mechanism is important in direct bacterial and fungal and fighting, while the T cells and B cell recruitment is important in viral infections. So you can see that the neutrophil is the first line in defense for the body for these organisms. Now, we will move to some of the important definitions. Febrile neutropenia is two components. So we have fever and neutropenia. Now, fever is defined as a single temperature reading of more than 38.3 or 38 to 38.3 for persisting for more than 1 hour. So this is fever. Neutropenia, we have an equation to calculate what is called the absolute neutrophil count, or the ANC. Now, if you remember from the slide, we have two types of neutrophils, band and segmented. So you will calculate the total, then you will multiply by the total white blood cells, and you divide by 100. So you will receive your absolute neutrophil count, which is the effective neutrophils part that represent the immunity. Now, if the patient have ANC of below 0.5, this is considered neutropenia, and he is at risk of infection. We have two other definitions: profound, if it is less than 0.1, so now he is more exposed to infections, or prolonged, meaning that neutropenia persisting for more than 7 days. Another important definition is the nadir. So when we say nadir, we mean that the point in time or at which day after chemotherapy, the neutrophil will reach the minimum count. So most anti-cancer therapy, they have a nadir of 7 to 10 days or 14 days. So by day 10 or 14, you would expect that the neutrophil will reach the minimum. Then after that, they will start to rise and count, mainly because bone marrow will start to synthesize again. So we have some exceptions, like some of the alkylating agents and mitomycin C, which is an anti-cancer. These few agents have a nadir of more than 1 month. So if you are using these agents, you would expect neutropenia to be prolonged even up until 1 month or more. Okay, so here are some important concepts to consider. Febrile neutropenia is an oncologic emergency because mortality is more than 50% if left untreated. Also, febrile neutropenia, if occurred, it can disrupt the anti-cancer management by delaying the cancer treatment, reducing some doses. All of this will compromise the anti-cancer treatment, and ultimately it will affect the survival of the patient. Another important thing is that the usual signs and symptoms of infections like pus, infiltration, raised white blood cells all are absent because of the dysregulated immune function. So you have fever as the only marker for infection. Now we will move to the pathophysiology. So I will talk briefly. You can find here all the details. So we have two major types of malignancies, hematological and solid organ. Now, hematological malignancies are cancer in blood cells. So this cancer occurs in the bone marrow where the blood cells are synthesized. So you can see here are a bone marrow sample, and all of these dots, blue dots here, are cancer cells. So in bone marrow with this crowdedness, you would expect that the other blood cells production will be reduced and dysfunctional. So moving to the solid organs, now solid malignancies, they are typically a mass of tissue. So this mass usually have necrotic surrounding, and this necrotic surrounding will provide a good environment for microorganisms to grow and nutrients. The other thing with solid tumors is that they can synthesize abnormal or new blood vessels to supply them with nutrients, and this also will benefit the microorganism. And also the solid tumors, they can invade blood vessels and destruct other mucosa or other tissues, and this will gain access to the microorganism to the blood. So the other component in the pathophysiology is the antineoplastic itself. So you know that the chemotherapeutic agents usually target rapidly dividing cells, especially agents that target DNA, because DNA is active in the rapidly dividing cells. So we have the blood cells and the bone marrow are part of the rapidly dividing cells. So neutrophils are targets to the chemotherapeutic agents. And we have also even the new targeted agents and immune agents. Some of them target some of the pathways that are important in the function of the immune cells. So they will also result in functional disability in immune cells. Also steroids, we use a lot of steroids in part of the anti-cancer management, especially potent glucocorticoid like dexamethasone. And these steroids, we use them in high doses. So by themselves, steroids have immunosuppressant effects also. Also, the last thing is that the chemotherapeutic agent usually disrupt the GI and the skin mucosa, which, as you know, are the first barrier against infections. So this is a bone marrow sample of patients who received chemotherapy. You can see this is a hypocellular bone marrow in contrast to the first slide that I showed you. So this patient will eventually have neutrophils because of this hypoplasticity. So here are some of the major risk factors for developing febrile neutropenia in these patients. I went through a lot of them: hematological malignancies, intensive chemotherapy, some of the targeted agents, and bone marrow failure syndromes. So the etiological agents, these are the major etiological agents. We have bacteria, virus, and fungi. And here are some of the commonly encountered organisms according to their class. Okay, so here are some of the antimicrobial classes that are commonly used. It is out of the scope of this presentation to go in details. However, you should know that what are the differences between each agent and each class. Mainly, we are concerned with the coverage. So you have to know which agent cover which organism. So penicillin class are one of the most commonly used antibacterials. We have cephalosporins. Also, we have other antimicrobials here. We have trimethoprim sulfamethoxazole. This is an antibacterial agent. However, you can find it used commonly against PCB, which is Pneumocystis jirovecii, which is a fungal organism actually. However, this antibacterial have activity against this organism. So we use it a lot in prophylaxis of this agent. So we have other antifungals, the major classes here. Antivirals, we will not go deep with them. However, acyclovir is a very important agent since you can find it commonly used in prophylaxis because it's covered most of the commonly encountered viruses. So here are some of the things to consider when choosing an antimicrobial agent. First, if you are in an empiric or definitive setting, it's important to choose an agent with a good spectrum of activity. So you have to know which agent cover which organisms, gram-negatives, gram-positive, Pseudomonas coverage, and other organisms. Also, we have some specific microorganisms that require specific treatment recommendation like MRSA, Pseudomonas, ASBL-producing organism. These organisms require specific treatments. And we have two other factors related to the pharmacokinetics. So renal dosing, you have to know which agents require renal dosing and can be used in renal disease patient, and the site of infection. If we have pneumonia, for example, which agent can penetrate into the lung tissues, CNS, which agent can penetrate through the blood-brain barrier, and so on. So here is our first case. SN is a 37-year-old female who are medically free, except she was diagnosed with breast cancer and she was started on chemotherapy AC regimen. So in day 10, she presented to the emergency feeling fatigued, complained of shortness of breath, dyspnea, cough with sputum. So her temperature is 38.5. Her labs reveal white blood cells of 5, neutrophil band 2%, neutrophil segmented 5%. So what is the likely diagnosis of SN condition based on these results? Is it A, febrile neutropenia because her ANC and temperature? Is it neutropenia but no fever, or fever but no neutropenia, or not febrile or not neutropenic? So I don't know, Dr. Inas, if you can see the...
You can see the column.
Okay.
You can see it?
Yes, I can see it here.
Yeah. Please answer question number 1 only, please. Please, only question number 1.
So how can we see the results?
You can see it, Dr. Abdullah?
I see only the choices, but the results, the answer results, I don't see.
A, okay, they are voting now. So, we'll wait. Most of them, they are answering A and B. Now,
Okay.
40% for A.
40% for A. Okay, so I think you need the equation. So if you calculate the equation, so the correct answer is A actually. If you use the equation that we presented, you would receive an ANC of 0.3, which is below 0.5, and temperature, we said that above 38.3, a single reading is enough to diagnose as fever. So the patient is febrile and neutropenic. Okay, now we'll move to the treatment section. So before starting treatment, it's important to stratify the patient according to his risk. So we have the MASC score. You can see here the component of the score. Pay attention that they are all negative components. So if the patient doesn't have symptoms, he will have more points. So the higher the point, the less the risk of the patient. And generally, we consider the patient high risk if he has a total score of below 21. So this is a high risk. Other factors that are not included in the score, hospitalization at the time of infection is a high-risk feature. If the patient received alemtuzumab, which is an agent used in the transplant or other hematological malignancy, this agent is very lymphotoxic and it results in immune suppression. So if the patient receiving this agent, he is considered high risk. If the patient has progressive cancer, abnormal organ function, clinical instability like hypotension, pneumonia, or neurological changes. So if your patient have any of these factors or the MASC score, he is considered high risk. Now, high risk patients, they usually should be hospitalized and receive intravenous broad spectrum antimicrobials. So empiric treatment, the important thing is that we don't wait for the results. We start the treatment as soon as possible. So why? Because as I said, febrile neutropenia is an oncologic emergency. You have high incidence of mortality. So you have to start with a broad spectrum antibacterial that covers gram negatives, gram positives, and Pseudomonas coverage is important. So always remember that there is local susceptibility data or antibiogram. This is institution specific. So each hospital or institution have their own antibiogram. Their organism have different sensitivity from other institutions. So this will guide you to which agent to choose from these broad spectrum agents. The other thing is that vancomycin, which as you know is used in the MRSA, is generally not recommended in the initial treatment, empiric treatment. However, there is some criteria to start vancomycin. You can find it here if the patient have MRSA colonization, meaning history, or if the patient is clinically unstable and so on. So if the patient was started on vancomycin, it's important to reassess in 2 to 3 days with strong consideration to discontinue vancomycin if there is no clear reason to use. So what if the patient is low risk? We usually treat these patients as an outpatient settings. Fluoroquinolones, oral fluoroquinolones are one of the most commonly used agents in the outpatient settings. So what about antifungals? Antifungals is used first if the patient have a history of fungal infection. Definitely if the patient developed febrile neutropenia, you would use antifungal in the empiric setting. However, if the patient have negative history, however, he have persistent fever, meaning more than 4 days fever on top of broad spectrum antibacterials. So this is the time to consider adding antifungal to the regimen. And here are some of the most commonly used antifungals. We have the azoles. Fluconazole is one of the most commonly used agents. However, there are some specific consideration. You can find it here, like fluconazole doesn't cover aspergillus. It only covers candida. So if the patient have history of aspergillus, it's important to consider the coverage here. This is important. Why? Because fluconazole is the most commonly used agent in the prophylaxis setting. So the patient may have already been on fluconazole and develop febrile neutropenia. So this is to consider using other agents. So when to stop empiric therapy? First, the patient has to be out of neutropenia. This is the first and most important thing. This is when you start counting other things. So if the patient is out of neutropenia, you have normal neutrophil counts, you will see the febrile pattern. If the patient is afebrile for at least 48 hours, so he is out of febrile neutropenia now. However, you should pay attention to the use if the patient used antipyretic, because this might mask fever. So this is important. So if the patient is out of febrile neutropenia, now you consider the duration appropriate for microorganism eradication. And this is a disease specific, so you can find it in the guidelines. For example, pneumonia, they state their specific duration. The patient has to complete this duration for each disease. Fungal infection, generally they require longer treatment. So now we'll move to our second case. So SN is the same case. She is diagnosed with febrile neutropenia. If you calculate the ANC, you would find it's 0.35. So on examination, she is tachypneic, tachycardic, and her blood pressure is 85/55. So chest X-ray was ordered. Sputum was sent for culture. Her medication include paracetamol PRN, metoclopramide, PRN. So what is the best course of action for managing the febrile neutropenia in this case? You can see the choices here. We have numbers.
Yeah, the 60% answered D.
D. Okay, good. So D is the correct answer. So the patient started on piperacillin tazobactam in combination with vancomycin. Now, piperacillin tazobactam have a broad coverage. It covers gram-negative, gram-positive, and even it can cover Pseudomonas infection. Why we added vancomycin? The patient have two indications here. So his symptoms from the subjective and objective data, you can predict that it's mainly pneumonia. And the other thing is that he is clinically unstable with hypotension. So these are some of the recommendations to add vancomycin. However, reassessment after 2 to 3 days is important here. Okay, now we'll move to the last part, which is prophylaxis. Now, again, risk stratification. However, the risk here is different from the treatment. So if the patient have low risk, meaning he is less likely to develop febrile neutropenia. This occurs when the neutropenia is anticipated to have a duration of less than 7 days. High-risk patients, on the other hand, if they are anticipated to have severe, less than 0.1, or prolonged, meaning more than 7 days. The other thing is that all leukemic patients are considered high risk for febrile neutropenia regardless of any other thing. Some of the strategies to prevent febrile neutropenia is chemotherapy dose reduction. However, if the intent is to cure the patient, we usually give full doses. We don't want to compromise the chemotherapy. So you can find in most of the protocols for chemotherapy, they state a threshold of ANC at least 1.5. If the patient doesn't fulfill this criteria, he will not receive the chemotherapy. Another important thing is hand wash and hygiene is very important. GCSF use, I will talk about it in the next slide. And also we have antimicrobials as a prophylaxis setting. So what about GCSF? So GCSF is colony stimulating factors. Now blood cells synthesis or hematopoiesis occur in the bone marrow. So what we mean by hematopoiesis is the production of the blood cells. So these blood cells originally come from a stem cell. These stem cells are immature cells that evolve and change to a progenitor cells. And then we have specific progenitor cells. Each progenitor cells can produce a specific type of blood cells. Now, how these stem cells and progenitor cells evolve and change is by the influence of what we call colony stimulating factor. We have two important factors, GM-CSF or granulocyte monocyte colony stimulating factor. This factor will differentiate the stem cell into a progenitor cell that will produce monocytes and granulocytes from its name. The other one is the GCSF, it's granulocyte colony stimulating factor, which is specific for granulocytes. Now we have two agents. Sargramostim is analog for GM-CSF, and we have filgrastim. Filgrastim is the most commonly used agent. It's an analog for GCSF. So by giving these agents, you are increasing the production of neutrophils and other blood cells. So as I said, filgrastim, we have other biosimilars. We have a different formulation called PEG filgrastim because filgrastim is usually given in multiple doses. This new formulation, PEG filgrastim, is only given once, which is feasible to the patient and to us also. So GCSF is usually given as a primary or secondary prophylaxis. Primary meaning we give it up front. We don't wait for febrile neutropenia to occur. Now, when we give GCSF as primary prophylaxis, it's generally recommended if the chemotherapy specific regimen is expected to cause more than 20% incidence of febrile neutropenia. And this, we can know this through the trials and through the data from the studies. So if this regimen is expected to cause more than 20% febrile neutropenia, you will give GCSF upfront, and even you will find it in the protocol built in with the chemotherapy. So other regimens that are not commonly cause febrile neutropenia, we don't give GCSF as upfront. However, some patients may still develop febrile neutropenia because of chemotherapy. So with subsequent cycles, we give GCSF as a secondary prophylaxis. These are some of the common side effects with GCSF. Bone pain is very important and very famous, and usually patients complain a lot from bone pain, and usually it's managed by non-steroidals or even paracetamol. So very important thing to mention about G-CSF is the administration timing. So G-CSF is usually given at least 24 hours after administering chemotherapy. Why is that? What will happen if we gave G-CSF, for example, 6 or 12 hours after chemotherapy? Think about it. From the mechanism of action, G-CSF will increase the production of blood cells and neutrophils, as I explained. And you know that chemotherapy target rapidly dividing cells. So paradoxically, if you give G-CSF before 24 hours, you might see exaggerated and even severe neutropenia. This is because you are increasing the production of neutrophils, and this will increase the target for chemotherapy, and they will destroy these neutrophils. So at least you would give 24 hours, you will give a chance for the body to clear the chemotherapy, and then you can administer the G-CSF. These are some of the antimicrobials that are used in the prophylaxis setting: antibacterial, fungal, and viral. You can find the specifics here. Very important concept to consider here is that antimicrobials is only indicated during neutropenic period. If the patient is out of neutropenia, he is no longer at risk of infection because his immunity is again normal and back. So this is the time to stop antimicrobial. And it's from practice standpoint, you would find a lot of patients who are continuing in their antimicrobial prophylaxis despite they have normal neutrophils count. Another important thing is to consider the nadir. So you have to ensure that the patient is post-nadir, meaning he already passed the 10 or 14 days after chemotherapy, so that you ensure that the neutrophil is again start to increase in counts. So now with our last case, SN, again, her sputum cultures revealed Pseudomonas aeruginosa, which is sensitive to piperacillin tazobactam. Now we are moving from the empiric to the definitive therapy. So the team decided to DC vancomycin and to shift her on piperacillin tazobactam. This is definitive therapy. So her febrile neutropenia is resolved after receiving antimicrobial with piperacillin with appropriate duration. Her white blood cells is A and C is 3, so now she is normal. She is not neutropenic anymore. She is clinically stable. Now the team decided to discharge the patient with a follow-up before her next chemo cycle. So what is the best plan to prevent febrile neutropenia in this patient? Okay, we have numbers. So about 50%, they answered filgrastim 24 hours after next chemo dose, which is right. This is the correct answer. Filgrastim to be given concurrently, never ever. Filgrastim 24 hours after NC, no, regardless of NC. So the best answer is filgrastim 24 hours after her next chemo cycle as a secondary prophylaxis. Thank you all. The questions now or at the end of the session, Dr. Anas?
Thank you, Dr. Abdullah. If you have any question, please type your question in the chat or raise your hand. Here العنود and Manayir.
We have a question. So only antibacterial prophylaxis if patients still neutropenic post-nadir. Definitely, if the patient is still neutropenic, even if he passed the nadir, you would continue the antimicrobial prophylaxis. The basic idea is that while the patient is neutropenic, he is at risk of infection. We use antifungal at the beginning only if patient had a history of fungal infection. If the patient have a history of fungal infection, in the empiric setting, you would use antifungal with the antibacterial as an empiric treatment and limit results. In cancer, patients have lack of undifferentiation or it's highly differentiated. طبعا this is specific for each cancer. يعني the differentiation, the pathologist will give you if the patient is, if the cancer cells undifferentiated, poorly differentiated, intermediate, or highly differentiated. طيب, there are some questions. Can we use corticosteroid for monotherapy chemo? No. Generally, it's not used as a monotherapy. It's usually combined with others.
I think here Manayir has a question.
Okay.
Manayir, you can unmute yourself and ask your question, please. And here also Muhammad. Muhammad, you can unmute yourself and ask your question, please. She didn't have question.
Okay, we have here a question by Mudawi. Based on what do I expect the febrile neutropenia for primary prophylaxis? So it's generally recommended if the febrile neutropenia incidence, this is chemotherapy regimen specific. So you would see your specific protocol and you would see the data. If there is more than 20% incidence of febrile neutropenia, you would use primary prophylaxis with GCSF. طيب, cancer cells have lack of undifferentiation. This is a repeated question. Can you mention which guidelines you follow in treatment and prevention? Generally, NCCN guidelines, they have a nice review for the prevention. We have also the ESMO guidelines. So these are the main guidelines we refer to. So do we have any other questions? طيب, any more questions? I hope إنها كانت clear.
Thank you, Dr. Abdullah. Thank you for this informative lecture. So now please welcome with me Dr. Adil Al-Nakhli. Dr. Adil is a hematology oncology clinical pharmacist in King Fahd Medical City. Welcome, Dr. Adil. Dr. Adil will talk about tumor lysis syndrome.
Assalamu alaikum. Can you hear me now?
Yeah, we hear you.
Good.
You can start.
The slides are up or still?
No, it's clear.
Good. Assalamu alaikum, everyone. Thank you for SOPA for giving us this opportunity. And thank you all for attending and bearing with us in this late evening. I guess now we have a short night during this summer. So I'll be talking to you guys about tumor lysis syndrome, which is another oncological emergency that we usually see from once in a while or frequently, actually, in if you are covering in hematology or oncology unit. So on this hopefully short and quick, easy presentation, inshallah, we'll define the tumor lysis syndrome. Then we will list some of the predisposing factors of developing tumor lysis syndrome. After that, we'll talk about the majority of the presentation on the prevention and on the how to stratify the patients based on their risk of developing tumor lysis syndrome. So generally speaking, tumor lysis syndrome is defined as a metabolic syndrome caused by the breaking down of the malignant cell. And this breaking down can be actually due to treatment of this chemotherapy, which is either traditional chemotherapy and other modality of treatments can cause tumor lysis syndrome, which can cause eventually the death of the cells. Other modalities of treatments include may include radiation, for example, medication as simple as steroids when used for treatment of cancer or hematological malignancies. Specifically, some of the newer medications, immunotherapy, targeted therapy, all of this can cause or lead to tumor lysis syndrome, as they can lead to cell death or cell lysis. Tumor lysis syndrome can also happen spontaneously. So if we have a large tumor, as we will see in some of the risk factors as well, this can be a predisposing factor by itself for tumor lysis syndrome. So what I have been saying in the previous slide is really depicted here in this picture. Let me just... So it's depicted here in this picture. So if we have this poor guy with lymphoma, and if we give the cancer treatment, eventually the breaking down of the cancer cell will happen. This is what we call the cell lysis. And then the content of the cancer cell will be introduced to the bloodstream. And tumor lysis syndrome is mainly characterized by hyperuricemia, which is a high level of uric acid in the blood, hyperphosphatemia, hyperkalemia, and hypokalemia, hypocalcemia, sorry. So as a result also with this lab changes, some other clinical manifestation can happen with tumor lysis syndrome. For example, acute kidney injury or renal failure, which can happen as a result of the precipitation of or the crystallization of uric acid in the kidney tubules. Also due to the result of the combination or the precipitation of potassium or calcium phosphate in the kidney tubules. Also abnormal heart rhythm or arrhythmias can happen either due to the hyperkalemia, which can, as you guys know, potassium affect the heart. Also due to the disposition also of calcium phosphate in the cardiac tissues, or as direct injury to the cardiac tissues. As calcium also become low in the bloodstream, muscles will be affected. So the patient will be having muscle cramps, muscle weaknesses, and seizure as well. So tumor lysis syndrome can be actually divided into either laboratory tumor lysis syndrome, laboratory tumor lysis syndrome, or clinical tumor lysis syndrome. First, we'll talk about the laboratory tumor lysis syndrome, which is the manifestation or the appearance of 2 or more biochemical variables that has to happen within 3 days before or 7 days after the cancer treatment. So from the start, 3 days, either 3 days before starting the cancer treatment, this when the spontaneous tumor lysis syndrome may be happening, or within 7 days of tumor lysis, of starting the chemotherapy. And all of this has to happen in the presence of adequate hydration and the use of uric acid lowering agents. So basically, as we said, we have to have, for laboratory tumor lysis syndrome, we have to have at least two of the laboratory findings or the laboratory variables that can happen, either hyperuricemia, hyperphosphatemia, hyperkalemia, or hypocalcemia. It's not only the increase of these by numbers or by the more than the normal lab values. Also, if they increased by more than 25% from their baseline. So if we have a uric acid of, let's say, 200 and increasing within after treatment to 420, which is still less than the normal level, I would be concerned, since the increase is almost by 50%. The other category or sub category of the tumor lysis syndrome is the clinical tumor lysis syndrome, which is, as per the Cairo-Bishop grading system, is the appearance of one criterion of the following, either increasing creatinine clearance, cardiac arrhythmias, or seizure. However, this has to be either by this has to be by one of the this has to be not caused by chemotherapy, because some of the chemotherapy, as you guys saw with Dr. Han yesterday, can cause seizure. So this could be attributed actually to as a side effect of the chemotherapy, not as a side effect of or not as a result of the tumor lysis syndrome. So here we have the first question. I don't know if Inas can do the poll, or we can just answer the questions.
I will do the poll.
So I'll read the question in the meantime. Tumor lysis syndrome is characterized by which of the following lab or electrolyte changes, and select all that might apply. So we have more than one answer, actually, one correct answer, let's say. Can we see the numbers?
Okay, you can see the result.
Okay, so I see that hyperkalemia is there, hyperuricemia is there, hypocalcemia is there, hyperphosphatemia is there. So good for you guys.
Dr.
So the
Ali,
correct, yes.
if you don't mind to share your to start the video.
Okay, just a second. I have to exit the presentation first. Is it up?
Yeah, clear.
Okay. So the correct answer is hyperphosphatemia, hypocalcemia, hyperuricemia, and hyperkalemia. So when it comes to risk stratification, actually we can see that it is mainly due to the type of the cancer cell that the patient has. And basically, most of the solid tumors have low risk of developing tumor lysis syndrome. However, we have to keep in mind that bulky solid tumor actually can have bulky solid tumor can exert or develop tumor lysis syndrome. Patients with bulky solid tumor can exert or develop tumor lysis syndrome, especially if these cancers or tumors are sensitive to chemotherapy. These cancers such as neuroblastoma, germ cell tumors, and small cell lung cancer, for example. And generally speaking, hematological malignancies are more, patients with hematological malignancies are more prone to develop tumor lysis syndrome than those with solid tumors. And when it comes to hematological malignancy, mainly myeloma patients are low risk of developing tumor lysis syndrome, and chronic leukemia still, some of them are low risk, except for those who receive treatment with high potential to lyse the tumor cells, especially on those with biological therapies. So those would be classified as intermediate risk for a disease. When it comes to acute leukemia, this is the bulk of the patient who develop tumor lysis syndrome. So we see here right away that Burkitt's lymphoma is directly classified as high-risk patients for developing tumor lysis syndrome. And when it comes to the acute leukemias, ALL, for example, here we have to look at other variables such as white blood cells and LDH. So if the patient has a low white blood cell and the low LDH, he or she will be classified as low or intermediate risk of developing tumor lysis syndrome. If they have a high white blood cells or a high LDH, they will be classified as a high risk of developing tumor lysis syndrome. Acute myeloid leukemia, same thing. If depending on the white blood cells, they will be classified to either high if they have high white blood cells, or to intermediate or low risk of developing tumor lysis syndrome based on their white blood cells and LDH. Also, there are many other classifications that have been used. And one main classification is for stratifying the patient risk. Patient risk is the looking at the cancer mass, looking at the cell lysis potential of the tumor, and the other medication that used with it, the patient characteristics, and the other supportive care that the patient is used. And all of this has been put on a very nice diagram by Ali McBride and his colleagues. So we see here for the cancer factors, for example, or the cancer mass, the higher the mass or the bulkier the tumor is, the higher the risk we have for developing tumor lysis syndrome. And then also for the cancer and treatment, if we have a treatment that we know it is effective, we know it will kill the cancer cells, then it will be classified as high cell lysis potential, and eventually it will be classified as having for the patient as having higher risk for developing tumor lysis syndrome. And then for the clinical risk, also as we discussed, other factors that we have to look at, also the pre-existing renal failure for the patient, or in general the patient factors that we will talk about in few slides, I think. So moving to the other question, if we can give the poll, please. Meanwhile, I will read you the question. Who of the following patient has the highest risk of developing tumor lysis syndrome? Is it a 60-year female patient with stage 3 breast cancer, 40-year male with AML presenting with low white blood cell, 17-year-old male patient with a 15-centimeter mass diagnosed to be Burkitt's lymphoma, or a 50-year-old female patient with CLL? So good. The majority of you answered correctly, which is C, the correct answer. So this answer, this question, or this C is the correct answer because we have a big tumor, this first. And the most important thing is because we have Burkitt's lymphoma as a diagnosis, and we established that patients with Burkitt's lymphoma have pretty much the highest risk for developing tumor lysis symptoms. So for the management of tumor lysis syndrome, pretty much if you look at all guidelines, ASCO, NCCN guidelines, or other experts' consensus for tumor lysis syndrome, they all agree that prevention is the key for the treatment or for the management actually of tumor lysis syndrome. And this prevention can be accomplished by recognizing the risk factors, which we talked about. I'm not sure if I skipped one slide. Let me just go back for a second. Yeah, this slide. So I didn't talk about this slide, which is, I think is important because we have to actually know the risk of our patients for developing tumor lysis syndrome. And all of these are, most of these actually are patient disposing factors for developing tumor lysis syndrome. For example, we have advanced age. We know that elderly patient come with acute kidney injuries, for example, or by nature, elderly patients have lower renal clearance. They are not eating well. They are dehydrated. This is where the other points comes into account. Volume depleted patients. Those patients are cancer patients. They might be affected by treatment, by chemotherapy. So they might be nauseated. They might not be drinking well. They might be not eating well. And those patients may be taking nephrotoxic medications. They are maybe on, for example, on antibiotics. Dr. Abdullah just talked to you that you have to know your antibiotics and what affect the renal function, what needs to be adjusted, and so on and so forth. Also, we have to know the baseline characteristics or lab values for our patient, white blood cell counts, creatinine, phosphate, and so on and so forth. We have to know about the comorbid conditions that the patient comes with. All of those can affect, for example, the cardiovascular systems, the renal system, patient with diabetes, for example. So all of these, we have to think about, all of these factors we have to think about when we are looking for a patient and evaluating if they are at a higher risk or a low risk of developing a tumor lysis syndrome. Also, as we talked about the malignancy type and the burden of the tumor, how bulky the tumor is. So sorry about missing this slide. I thought it is an important slide, so that's why I went back. So moving on and talking about the prevention, as we said, recognizing the risk factors of the patient, close monitoring of the patient who we think are at higher risk of developing tumor lysis syndrome, also appropriate interventions and when we have to jump in and add interventions. So first and foremost, most guidelines and the most important thing that we have to get out of this presentation is the importance of hydration in tumor lysis syndrome. So basically, we have to keep the kidney or the urine output flowing and at a high point by hydrating the patient. There is no actually specific numbers that we can aim, but most of the guidelines and most of the consensus put a number between 2.5 to 3 liters of fluids per day. For adults, also this might be different or might be changed depending on your patient. Actually, if you have a fluid overloaded patient, then you have to adjust these fluids. So you have to keep a high urine output just to increase the urine output and decrease, by doing that, decreasing the electrolytes that can go out with the urine, like the phosphate, potassium, and uric acid. The type of fluid that we can use, mainly we use dextrose with half normal saline and normal saline. There is no actually specific fluids that we should use, but mainly these are used. However, when selecting the fluids, also we have to take into account the amount of potassium, for example, that is in the fluids, not to exaggerate the problem or the issue. Alkalization, or increasing the pH of the urine. On the old days, they used to do this. However, currently is not recommended because this can increase the precipitation of uric acid in the kidney tubules, which can aggravate more the acute kidney injury. Also, it can participate in the crystallization of uric acid in the kidney tubules also. So management of electrolyte disturbance, I think you guys are by now expert by this. However, I'll go through this quickly. So if we have hyperphosphatemia, for example, depending on the severity of the hyperphosphatemia, we can use phosphate binder like sevelamer, for example. If it is so severe that it cannot be managed by medication, dialysis can be used. For hypokalemia, depending on the patient, if they have symptoms or if they are asymptomatic. If they are asymptomatic, usually no therapy is required. If they are symptomatic, then calcium gluconate can be used. We have to keep the patient on ACD monitoring just to avoid or to catch any arrhythmias that might happen. For hyperkalemia, if moderate and asymptomatic, then avoid all the oral potassium. Most of those patients are on hydration, on electrolyte replacement, for example. We can use K-exilate or sodium polystyrene sulfonate. If it is severe, then calcium gluconate can be used on top of the what we used for the moderate. Regular insulin with dextrose can be used, sodium bicarbonate. And if it is too severe that is not managed by this medication, dialysis can also be used. For renal dysfunction, we have to manage the medication. We are the expert. We know what medication is affecting the kidneys. We know our adjustments, so we have to implement all of these. And then the fluids and electrolyte management will also help with the renal impairment. So for the management of the hyperuricemia, this is where actually most of the medications or the, and one of the most expensive medication is employed here for treatment or management of anti-prevention of tumor lysis syndrome. So I think when you see this, you think it is only allopurinol, risperidone, or other medication that can be used. However, we have to keep the hydration going, and we have to make sure they are the hydration is there. So actually, first and foremost, for the management of hyperuricemia is hydration, 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 hydration. I cannot emphasize this more. And then comes also the anti-uremic or anti-hyperuricemia medications. So for the management of hyperuricemia, also depending on the patient and the risk of having tumor lysis syndrome, all of these are done for the prevention, as we say. And then comes the treatment or the prophylaxis also part. So if the risk is negligent or negligible or low, then we have to monitor less frequently. Daily monitoring is fine. And then hydration, oral hydration can pass by. However, if the patient is in the hospital, they already have an established IV cannula or IV line, then we can move to intravenous fluids plus the oral. We always encourage the patient, if they are taking orally, to take good hydration and be well hydrated. We can choose not to give anything. However, most of the time we choose, especially if they have a potential or a slight risk of developing tumor lysis syndrome, we go with allopurinol, oral allopurinol. If they have intermediate risk, you see that the laboratory monitoring increase. We do BID or even TID monitoring of the uric acid and other electrolytes. We increase the hydration, we keep it going, make sure that it is there. And here we can see the start of using either oral allopurinol or Respiratory, or both actually. If we know that our medications, as we said, has a high risk of a high potential of lysing the tumor and hence developing tumor lysis syndrome. So we can see as early as the intermediate risk the use of Respiratory. When we reach to the high risk or established patient with laboratory tumor lysis syndrome or established clinical tumor lysis syndrome, we see more frequent laboratory monitoring. Also, patient might be advised to be shifted to ICU if they have established clinical tumor lysis syndrome. I think most of our hospitals with oncology beds or oncology units are expert now in dealing with tumor lysis syndrome. So unless the patient is really, really sick and need to go to the ICU, most of the oncology or hematology units are able to take care of those patients with clinical tumor lysis syndrome even. We see the fluids again and the use of Respiratory with the established or high-risk patients. So quickly, we'll go over the medication. Allopurinol is the xanthine oxidase inhibitor. It prevents the development of uric acid crystals in the renal tubules, and it has no effect on the already deposited uric acid. That's why this is an important note for you guys. That's why we only use it for the prevention. As in the previous table, we use it in the prevention of tumor lysis syndrome, not in the treatment or in the established for the established tumor lysis syndrome. So if the uric acid is already crystallized, allopurinol will not help us. That's why we go for other modality of or other choices of treatment. We should start usually for the chemotherapy. If you have seen a chemotherapy protocol, you would see that allopurinol, if it is employed there or it is needed there, you will see it is started before before starting the chemotherapy or the treatment, and continued for at least 7 or sometimes more days post the treatments, depending on the lab values. So we have to make sure that the patient is, or the risk of tumor lysis syndrome has passed. That's when we are comfortable removing or discontinuing allopurinol. Of course, hydration, we have to always make sure it is there, and higher doses that might not be seen in other indications like gout can be employed in tumor lysis syndrome, and it needs adjustment for renally impaired patient. Respiratory, which is, yes?
I apologize for interrupt you, but you have 2 minutes.
Okay, I'm finishing up in 2 slides actually.
Okay.
So for Respiratory, recombinant urate, it's a recombinant urate oxidase. It converts the uric acid to allanitoin which is a soluble metabolite. So if we convert it to this soluble metabolite and we increase the urine output, we make sure that it goes away with the urine, and it breaks down the deposited uric acid, and it does not inhibit the formation. So that's why we see sometimes both Risperidase and allopurinol used together. It is contraindicated in hypersensitivity for the drug, of course, and for those patients with history of hemolytic reaction. And important that for most of our patients, once they are admitted, we will do the glucose 6-phosphate dehydrogenase to see if they are deficient on that or not. Because if the patient is deficient and they receive Risperidase, they might go into hemolytic reaction and they might die actually out of that. Hydration, we have to make sure it is there. It doesn't need adjustment, and it is given IV over 30 minutes. And this is, I think, my last slide before the question. Plasma uric acid should be monitored post Risperidase. We monitor it 4 hours after the administration, and then 6 and 8 hours until the tumor lysis syndrome resolve. And this is for you guys. You have to know some of these lab caveat, let's say, that blood must be collected for uric acid sample, must be collected in pre-chilled tubes containing anticoagulations to prevent the degradation of uric acid. So you will not get a false negative, let's say. And it has to be immediately immersed in ice and sent to the lab. When they do it in the lab, they have to do it in pre-cooled centrifuge. And then the sample must be processed and analyzed within 4 hours of collection, just to avoid any lab errors or lab readings. So this is the question, the last question, and I have several slides after that, but I was planning to skip actually for you guys to read in your own. So for this, for patient with high risk of or established clinical tumor lysis syndrome, which of the following treatments should be administered? Should we give allopurinol alone? Should we give hydration, allopurinol? And so great, you guys, the majority of you, almost 80%, gave. I'm glad nobody chose no treatment should be given. So for you guys, this you have to go through just to give you an idea of which doses should we use for Risperidase and where we can save some money actually when we use the flat dosing, flat single dosing, should I say. And finally, there are other medications that can be used. However, I haven't really seen any of them used, mainly Risperidase I have used in my institute at least. But I have been seeing colleagues asking for them as Risperidase is in short supply currently. And finally, I will leave you with this saying from Ali McBride, who is the most person who I think researched or wrote about tumor lysis syndrome. And he stated that all oncology patients are at risk of developing or at risk of tumor lysis syndrome. And then we have to know our patient, and we have to know the monitoring and prophylaxis for managing tumor lysis syndrome. And with this, I will leave you guys. Thank you for bearing with me, and thank you for listening and participating.
Thank you, Dr. Adil. Thanks a lot.
You're welcome.
So please welcome with me our last speaker, Dr. Noha Farid. Dr. Noha is a clinical pharmacist, adult hematology and oncology in King Abdullah Medical City in Jeddah. Dr. Noha will talk about the principle of cancer pain management. You can start now, Dr. Noha.
السلام عليكم.
وعليكم السلام.
طيب الصورة واضحة؟
كلير دكتورة.
طيب تمام. Okay, so my talk today will be simple, easy, inshallah. Mainly, I will talk about major or principles in treating cancer pain. Only the important big topics. My objectives will be first to define the pain and utilize the proper scaling tools that we will see together. Then you should be able to identify common causes of pain in those patients. And then we will utilize the common or famous WHO pain ladder. And finally, we will go through those medication used for pain management in details. So we will start by the definition. There are many definitions for pain, but the most common by the IASP is any unpleasant sensory or emotional experience that is associated with actual or potential tissue damage. So يعني هم طلبوا مني أشرح لكم كمان برضو بالعربي. فالactual or potential tissue damage يعني فعلا إذا كان مثلا عملوا surgery for a cancer فعليا، أو إنه كانت مثلا مجرد استخدام لإبر أو أشياء بسيطة ما كان فيها tissue damage بقدر السيرجريز مثلا، أو مجرد وصف المريض لهذا الألم. Our main goal for pain management, and this is the most important thing, that we want to optimize the patient comfort and function. At the same time, we want to avoid unnecessarily adverse effects. So we want to balance between the efficacy and toxicity. Now let's know from where those patients can get the pain. Some of those pain could be categorized under cancer-related pain or other causes. So for cancer-related pain, some of the cancers actually are associated with more pain than others because of their type of cancer or site, or if they were in a vital organ or sensitive organ. So like pancreas or bone cancer, lung cancer usually are associated with most severe pain and sometimes also associated with neuropathic pain. Also, if the cancer has been metastasized to the bone, this also will lead to cancer-related pain. Other causes, it could be related to the treatment that you are giving for this cancer, or other like the chemotherapy. And I think in the pharmacology presentation yesterday, maybe you came across a couple of chemotherapies that can cause pain, specifically neuropathic. صوتي واضح لأني فجأة ألاقي الشاشة راحت.
قطع صوتك فجأة دحين واضح.
Okay.
You can share your screen.
الشاشة واضحة.
أيوة الآن واضحة.
تمام. Okay, good. So the other causes, mainly because of the test and investigational procedure that we do, like a biopsy, bone marrow test, all those consider painful to those patients. Okay. So after we knew the causes, it's important to transfer this subjective information, because we know feeling the pain is actually subjective to how the patient feels. So we change it from subjective to an objective data, so we can finally analyze or choose the proper treatment and management for this pain. So many people have been putting some scales for assessing pain. Those are the most common. They are all in one figure, but actually they are several. So this is the numeric, and we have the visual. It's visual. Usually, it's very helpful in patients who are like very young, pediatrics, or people who in expressing their pain with number. So you can just see how they visually express. This will make your pain assessment very easy. So whatever above the score of 6, usually it's severe, and more severe than the worst severe. Why this is important? Because we have a tool actually, or a ladder that has been developed by the WHO. Actually, it's very old, but it helped many practitioners to assess the pain and choose the proper treatment for each pain without reaching to unnecessarily toxicity, which is again our goal of therapy. So this is the WHO pain ladder. We have here the mild pain with the previous scoring that I mentioned, usually less than 4, mild to moderate from 4 to 7 or 4 to 6, and then we have the severe pain. For each step, we have a recommendation by WHO in how to manage this pain. So for mild pain, you can see here, we can use the non-opioid in addition to adjuvant therapy. We will come across the adjuvant therapy in details in my last slide. So you can see adjuvant therapy can go with you in all steps. Second step, then you can have adding to the non-opioid, you can add weak opioids, and then you can go with the strong opioids. With time, many practitioners saw that this ladder may need some modification, because unfortunately, sometimes cancer patients still have a difficult pain to manage, even with the medication that I mentioned now. So they were recommending to have a fourth actually step, which include the unresponsive pain for those patients, and usually it will contain management by more difficult or intense modality like the intrathecal opioids or nerve stimulation process. Okay, after we knew uh, um, the scoring of the pain and the pain ladder, it's also important to know the pain types. This also will help you to choose the medication. So we have two major types, nociceptive pain and the neuropathic pain. We'll start with the neuropathic pain. Neuropathic pain, actually, any pain that can involve your CNS and nerve system. And usually it's the sensation of neuropathic pain is different than nociceptive pain. Neuropathic pain, we have two types, the peripheral and the central. So peripheral, anything in your periphery. Peripheral nerves, like in your hands, legs, feet, like this. For central, it will involve the CNS itself. So for peripheral, again, we have a couple of causes that can cause peripheral neuropathic pain. Most common is the chemotherapy, and sometimes it could be due to tumor invasion and compressing the nerves. For the nociceptive pain, mainly it will affect the tissue, not the nerves, okay? So tissue, it could be either the visceral or superficial or deep. For visceral, it could be actually pressed by like lymph nodes. Superficial, that means it will affect the superficial tissue, like the lining of the buccal mucosa, for example, like in mucositis. Deep somatic, it will involve deeper organs and tissue, and it can mainly it is by tumor infiltration and metastasis. Okay. Okay. So now we have the pain types, and we have the WHO ladder, and we have our goal, which is we want to have a good control of the pain with less toxicity. Now we are ready to start the treatment. We will start with the non-opioid agents. We have our famous um, paracetamol. Paracetamol, considered one of the most common used non-opioid pain medication. So I will make a deal with you. Each group of medication, we should know the mechanism of its efficacy and toxicity. And therefore, you will understand everything and know how to use it and prevent the toxicity. So for the paracetamol, mainly its effect, we know it's analgesic and antipyretic, and those two effects actually are due to inhibition of central prostaglandin. But unfortunately, they or paracetamol does not have any anti-inflammatory effects. Okay, so let's move to the toxicity. If we looked here into the paracetamol metabolism, it's a hepatic metabolism. Those are the two major metabolites. We here we will focus more in the N-acetyl P-benzoquinone, or the NAPQI. This is the most important metabolite. Why? Because accumulation of this metabolite will lead to hepatic toxicity and to minimal extent renal toxicity from acetaminophen. For that, you will see that for paracetamol, you are limited with a maximum daily dose that you cannot exceed, which is 4 gram. Whenever you exceed this dose, you are putting your patient at risk for accumulation or having more toxic metabolite and therefore toxicity. That's why also we adjust if there is any impairment in hepatic in the hepatic function. Um, Even though it's very common, but we don't use paracetamol alone in cancer patients that much. The second group is the non-steroidal anti-inflammatory drugs. We'll start with its mechanism of action. So it's similar to acetaminophen in inhibiting the prostaglandin, but specifically they inhibit the production of prostaglandin by inhibiting the cyclooxygenase enzyme specifically, COX-1 and COX-2. Both of those enzyme, inhibition of those enzyme will lead to prostaglandin inhibition and therefore reduction. And therefore you will have your anti-pyretic, anti-inflammatory, anti-analgesic effect. What's special also about NSAID, in addition to their extra anti-inflammatory effect, that specifically the COX-1, which is responsible for continuing of this process. So prostaglandin H2 will transfer to thromboxane, and therefore thromboxane A2, which is important for platelet aggregation and thrombus formation. This process will only continue with the availability of COX-1. So inhibition of COX-1 specifically, not 2, will lead to inhibition of this process and therefore inhibit platelet aggregation. Let's talk more about the COX types. So COX-1 is available in most of the tissue and also in the platelets. That's why it has this unique mechanism in inhibiting the thromboxane A2, unlike COX-2. COX-2 also available in many tissues, but maybe less than COX-1 and it's not available in the platelets. And that's why theoretically we assume that COX-2 are more safe in terms of GI toxicity and bleeding risk. So again, this one I'm just emphasizing on the effects of non-steroidal, the antipyretic, anti-inflammatory analgesics. They're all due to prostaglandin inhibition. For the anti-inflammatory, we have a specific also like criteria for the non-steroidal that they are all acidic medication, and they have the acidic dissociation constant, or the pKa usually is low for those medications, and that's allow them to enter the inflammatory site easier, because usually the inflamed site has a low pH, the normal joints or normal sites. Finally, the antiplatelet effect, also it's unique for the non-steroidal, not like paracetamol, and we explained the mechanism. Here are examples of our non-steroidal anti-inflammatory medication based on their action in the COX enzyme, either to be like specific for COX-2, like Celebrex, or specific for COX-1, like aspirin, specifically the low dose. And then we have a couple more of examples that are in between. Okay. After renewed the effect, here is the most common side effect of non-steroidal anti-inflammatory medication. And again, it's important to know the mechanism of those toxicities. So we have mainly the gastrointestinal toxicity, cardiovascular toxicity, and renal toxicity. The gastrointestinal toxicity is mainly because of the disturbing of the mucosal secretion, and also due to the vasoconstriction, allowing for or inhibiting blood flow to be delivered to the mucosa, and therefore you have less cytoprotective effect, and therefore this will lead to ulceration or GI toxicity in general. Cardiovascular risk. This risk actually also associated with other risk factor, mainly patient risk factor like the age and consumption of tobacco and alcohol. The mechanism of cardiovascular toxicity with NSAID usually due to the inhibition of salt excretion and hypertension secondary to vasoconstriction. This all can lead to cardiovascular toxicity eventually. Renal toxicity, again, is due to vasoconstrictive effect secondary to inhibition of prostaglandin. Luckily, it's reversible. Again, there are a couple of risk factors that are associated with more risk to develop renal toxicity, like heart failure and cirrhotic patients. Those are, again, the examples of non-steroidal anti-inflammatory, but based on their origin. So it's the same example. Those are the most common. There are many non-steroidal, but those are the most common that we see in practice. Okay. So again, final points about non-steroidal. So all of them have the same effect. The choose between one over another would be the COX selectivity and safety profile mainly, but not the efficacy. We never combine two non-steroidal together, because this will never give you better analgesia. It only will increase the toxicity for this patient. The good thing about non-steroidal that they don't cause tolerance. If you're wondering exactly what is tolerance, so tolerance, we will see that with opioids mainly. Tolerance is whenever you are giving the same dose, but then you're not getting the same pain relief or effect. So you used to be in, like, for example, Celebrex 200. You will never stop having the effect from 200. So it's the same effect all over the period of use. But they have therapeutic ceiling, again, unlike opioids. That means that there is a maximum dose that even if you increase the dose after that, there is no effect, only side effects. Okay, again, non-steroidal, actually with those side effect profile, they sometimes limit, they have limited use in cancer patients because of the nature of their disease and complications. Okay, so let's see our case. I started very easy, actually. إيناس، هي الشاشة واضحة ولا لا؟ لأنه أنا عندي هنا يبين ما هو واضح. Okay, okay. Okay, so here is the first case. Easy, straightforward. 30 years old female diagnosed with Hodgkin lymphoma. She enjoys her life normally, but complaining of mild pain sometimes, could be related to her cancer. What would you recommend? I think I will just skip using the barcode because whenever I'm using it, the screen is disappearing.
Okay.
It's okay. I made up a plan B. So what would you recommend?
I launch the poll and they will answer here.
Okay, great. Thank you, Anna. So she wants just to remember the question. Okay, excellent. I thought I will get 100% for the paracetamol, but still 86% is satisfying for me. Okay, so yes, we will use a non-opioid for this patient. As we said, this is a mild pain. We won't go for pregabalin or this consider adjuvant therapy because the patient did not complain of uncontrolled pain or having specifically neuropathic pain. Tramadol, I would consider if it's a moderate pain, maybe moderate to severe. Okay. Okay, let's move on. Okay. This is the second question. We have a patient, 45 years old, with diffuse large B-cell lymphoma and the cancer-related DVT on therapeutic anticoagulation. He was prescribed Celebrex to be started for his ankle pain and inflammation. So the question is, what would you recommend to avoid possible non-steroidal anti-inflammatory drug side effects? Okay. Okay, so let's explain this one. Let's see the first which answer is right. Actually, it's adding a PPI or a gastric protective agent, usually PPI. Okay, so this patient considered ibuprofen instead. This is unfortunately totally wrong for those who answered. Because as we mentioned before, the COX-2 inhibitor like Celebrex will be more safe to GI than other non-steroidal. So ibuprofen is out. Let's talk about answer B and C. So if you look into Celebrex, like drug monograph or counseling point, they never emphasize in using Celebrex with food. And that's mainly because the assumption that it has less toxicity on the GI. So it's not necessarily to be taken with meals. But the most important thing here that you have a patient with full anticoagulation and non-steroidal anti-inflammatory effect. This will increase your ulceration or GI maybe bleeding risk. So you need a protective agent. So we will use omeprazole. Okay, I hope the ones who answered C now understand and convinced. Okay, let's go to the final group, which is opioids. So opioids are the most common medications that we use in cancer patients. So mainly their effect is based on their action in the opioid receptors. So we have the mu and kappa and gamma and delta, sorry. So those are the major receptors for opioids. All those receptors will cause inhibition of the glutamate release and therefore inhibit the transmission of nociceptive stimuli, and therefore they will affect your pain. They will affect your pain sensation and will help in releasing pain. But the important thing about those receptors that each opioid that we will learn about in next slide will work in specific receptors. Some of them work in all of them, and some are specific in like, for example, the kappa. So it's important to know what kind of toxicity or effect that may be caused by binding to this receptor. So for the mu receptor, we have mainly the respiratory and constipation, because binding an agonist to this receptor will reduce your sensitivity of central and peripheral chemoreceptor of hypercapnia, and this will lead to respiratory depression. Also, it will inhibit your gastrointestinal tract secretion and peristalsis, which is the movement of the GI, and therefore it will lead to constipation. Also, it have other toxic effect in the cardiovascular system. For the kappa, unlike the mu, it actually does not cause any respiratory depression. This is an advantage, but it's more responsible in the hallucination and sedation and this dysphoria effect. For the delta, it's actually involved more in the analgesic action and regulating the mood. Also, it can cause a decrease in GI motility and therefore constipation, and also it has a role in the respiratory depression. Let's see our opioids. So this is a very important table, actually. I tried to put the major or the most common opioids that we use, but this is not all of them, of course. This is they are. I put like the weakest, then the most potent at the end. I excluded methadone because actually methadone has an additional mechanism of action in excreting the serotonin, and that's why it has actually an effect sometimes when patients fail other opioids. So it's not included in this ranking from weak to most potent. Anyway, so here is the origin. Why I care about the origin is for synthetic, and for natural, SS is for semi-synthetic. The origin usually is important to you to see the allergic effect for those opioids. So if the patient developed like allergic or pseudo allergy, as we will see later, from one opioid, one of the options that you can change to another opioid from a different origin. And this is what I told you about the mu, kappa, and delta. For example, tramadol, no effect on kappa and delta. You'll see, for example, oxycodone, no, it has effect on all, most likely without the delta. Morphine, all of them. So whenever their potency, their binding to mu is more, then you'll see the side effects more. So for example, morphine, even with lower doses, we can see the constipation or respiratory depression, unlike oxycodone, for example. So this is how this helps. Half-life, I just mentioned the major short-acting opioids as we use the weak or short-acting for the moderate pain, and then we can go further with the more potent or longer half-life. Dosage form actually is very important in opioid because not only oral is a good option. Oral is not a good option always for all patients because we have patients who are suffering from nausea and vomiting or severe mucositis that cannot tolerate oral, for example. So we will go to another route of administration like parenteral or rectal, and sometimes like in fentanyl, we will also explain that in detail, the transdermal or patches. Specific recommendation for each one or specific like criteria for each one. As you see here that tramadol has only weak agonist to mu and nothing for the kappa and delta, and that's why you'll see the respiratory depression incidence is lower than other opioids, and it has very good oral bioavailability also. For morphine, one of the major important points is during the metabolism of morphine, you will have an active metabolite which causes morphine 6-glucuranoid or the N6G. Actually, it's not an active metabolite, but it's a toxic metabolite, and its accumulation leads to severe neurological side effects. And that's why we don't recommend morphine in renal impaired patients due to the risk of accumulation of the M6G. On the other hand, hydromorphone is safer actually for renal impairment than the morphine. Fentanyl, one of the agents that is actually very potent. It's 100 times more potent than morphine, and it's lipophilic, so the IV from fentanyl has a very rapid onset of action. And as I mentioned before, we will talk about the transdermal route for fentanyl. Methadone actually has a very long half-life and no active metabolite, but it has very high risk for QTc prolongation and drug-drug interaction. That's why usually we keep it as a last option, especially that it, as I mentioned before, work for patients who are not responsive to other opioids due to the different mechanism of action. This also an important information about opioids. So whenever I'm having toxicity or patient is not responsive anymore to such an opioid, mainly toxicity, we go to something called opioid rotation or switching from opioid to another. So if I want to switch from opioid to another, for example, morphine to oxycodone or any other opioid for any reason, I should follow this equianalgesic dosing table. Also, it's important to know this table when I want to discharge patient on oral form and he was on parenteral form. So for example, inpatient who is on 10 milligram morphine, upon discharge, I would do 30 milligram equivalent of the oral. Um, okay, so fentanyl transdermal patch. I wanted to talk about this specifically because it's one of the very important route or medications for pain that we use in patients, in cancer patients. Usually we use it only for the patient who are stabilized in an opioid dose, not initially when I want to figure out the proper opioid dose for the patient. It's a very useful route, transdermal patch, as we have, as I told you, we have a lot of patients that cannot tolerate oral. And also sometimes, especially in palliative patients or elderly, we have also hard parenteral access or for those patients. So transdermal patch brought us a very good route of administering opioid in those patients. Okay, so this is the fentanyl transdermal patch actually. It has the adhesive layer. First the protective layer, then the adhesive layer. Then here is your drug, and this is the package. Then there is a release membrane. So actually the adhesive layer here has some content of the drug. And the other is here in the reservoir. So initially, when you use the transdermal patch, he will have two phases of release. The first one that will release all the medication in the adhesive. So sometimes it could be like high peak. Then you will get the sustained release from the releasing membrane, and this should be a stable or steady state. There are many many important counseling points when using the transdermal patch, starting with the site of use, and that the site should be clean with no hair or cuts or wounds. This is very important. And the patient should try different area each time when they change their patch when they finish the dose. Those are other important notes about the transdermal patch. Usually, because it's a transdermal patch and it has a specific releasing mechanism of the medication, so usually it takes 8 to 24 hours to initiate or to have an onset of action. For that, you have to make sure that your patient is still on PRN dosing of other opioid, but not the around the clock, only the PRN dosing. Also, a good thing about the transdermal route, it passes the GI absorption and therefore the first pass metabolism, and that's make you lead to using lower doses with the same effect. So this is a very good route of administration. Other thing is it's not recommended for children, has not been studied in terms of safety, and it's not suitable for cachectic patient because this is a transdermal patch, so it needs a subcutaneous fat to be transferred through. So the cachectic patient may have or experience an overdose sometimes or unpredictable levels of fentanyl in their body. Finally, for this sustained release with this transdermal patch will allow you to have the dose every 72 hours. And in some rare cases, they may need it every 48 hours, but very rare. I've never experienced such patient. So usually the dose or the time to change your patch is every 72 hours. Elimination half-life, this is important, still there up to 18 hours even after your patch is removed. Okay, so let's go to the opioid toxicity. So we have the actually many toxicities. We'll start with constipation, and we knew that the mu and delta receptors are most likely responsible for this constipation due to decrease of the GI motility. So it's very important to consider a prophylactic measure for those patients, especially those taking opioid regularly, not only PRN or as required. Usually, the recommended prophylactic measure is a stimulant laxative plus minus polyethylene glycol. Stimulant laxative, for example, like Senna. Nausea and vomiting. Okay, so nausea and vomiting is usually secondary to continuous exposure of opioid. It can easily be managed by anti-emetics like metoclopramide, PRN. The third is the respiratory depression. Usually, respiratory depression, this is like an advanced stage of toxicity, actually. You can solve the respiratory depression by either decreasing the dose of the opioid or the frequency interval. If it was like every 8 hour, I just make it every 12 hour, for example. Those are all effective ways to reduce the respiratory depression. Pruritus. So pruritus is also common with opioid, and sometimes it's misdiagnosed with allergy. Uh, Pruritus actually it is secondary because of histamine release with the opioid, and it also can be managed by switching to another opioid mainly, as I mentioned before, especially if it was different origin. Then we have the sedation. This is a very advanced also toxicity of opioid. And we have some cardiac toxicity in terms of bradycardia and hypotension with the opioid. So for severe toxicity or uncontrolled toxicity, for example, the respiratory depression or sedation, those considered severe, or even in constipation that are not responsive to treatment or management, we can either, as I mentioned before, consider opioid switch or decreasing dose, or we can use the opioid antidote, mainly the naloxone and naltrexone. And there are many regimens in how to use naloxone or naltrexone, either to completely reverse the effect of opioid in cases of opioid toxicity, or when I want to consider the antidote or the antagonist in managing side effects of opioid by administering lower doses of the antagonist. Okay, so we have the third question. You are in the counseling window in the outpatient pharmacy with a prescription of fentanyl patch. The question is, what information would you counsel the patient about? Is it? Okay, I'm very happy. Yes, all of the above, of course. So there, as I mentioned, there are very many counseling points for fentanyl patch, and it's really important to know them and teach your patient about them also. Okay, so yes, all of the above. Last case, patient with breast cancer, with bone metastasis, complaining of severe back pain, interfering with her daily home activity. And the physician prescribed her morphine 10 milligram orally 3 times daily plus 2 milligram oral every 4 hours as needed. Today, she came for pain assessment and she denied requiring any PRN doses. Okay, what is your suggestion in this visit? Maybe. Okay. Okay, let's see the answer together. Okay, let's explain then. So this patient actually came with 10 milligram 3 times daily and PRN that she did not require. This means her pain is controlled on 10 milligram 3 times daily, which is equivalent to 30 milligram a day. Why would I change her to morphine 20 every 12 hours sustained release? I'm increasing her dose that she don't require, and this in this case I will put her at risk for toxicity without need. Adding Celebrex, no need again, because it's clearly mentioning that she did not require PRN doses and she's responding very well with this morphine, so no need for Celebrex. I intentionally wanted to mislead you with the back pain and bony pain, but so this is not the right answer. As I mentioned before, to avoid the toxicity, and one of them is the constipation, especially with patient taking regular morphine daily, and she is taking 30 milligram a day daily. I should add protective agents to prevent constipation with the stimulant, for example, like Senna. Okay. Finally, we reach the adjuvant therapy. The adjuvant therapy that was in each step in the WHO letter as add-on, either to add it or not. So what is adjuvant therapy? Adjuvant therapy, actually any medication that has like other primary indication other than pain, but also at the same time it showed analgesic property and it was very successful in some painful conditions. We have a lot of groups consider adjuvant therapy. We will talk about the most two important ones or most common, which are the anti-epileptic drugs and antidepressants. The goal of those patients, the goal of those therapy, to add them, is either to minimize the dose of, for example, the opioids or the other pain medication, so you minimize the risk of toxicity, or if you have difficult pain that need to be treated with different modalities. Other thing, if you have different type of pain, we mentioned that before, we have many types of pain. So if I have neuropathic pain, in addition to the nociceptive pain or tissue pain, I will consider an adjuvant therapy. Okay. So we said we'll talk about the two major groups, the antidepressant and the anti-epileptics. Both are very effective, actually. The antidepressant, as you can see here from the slide, has more toxicities again or complications than the anti-epileptics. Both are very good in managing cancer-related neuropathic pain. Antidepressant, in addition, has a very good effect in the mood and sleep that can be impaired with pain. Also, it's good if the pain the patient is having episode of depression secondary to the pain. Unfortunately, it's not recommended to use them in elderly patients because the risk of drowsiness and urine retention and complications. Also, it is contraindicated for patients with glaucoma or suicidal effects. So for anti-epileptic, we don't see those side effects common. So it's another good option, especially for neuropathic pain. Again, it has less drug-drug interaction and more tolerability compared to the antidepressant, tricyclic antidepressant. So finally, just to remember some points, we can combine opioid and non-opioid according to the WHO ladder. I hope you apply this knowledge, like the pharmacology, the kinetics, mechanism of action, and how to prevent toxicity whenever you're providing a care to a patient. Also, this is very important. We said before that our goal is to minimize the toxicity and prevent pain. But you have to know that pain sometimes, especially in cancer patients, is not 100% relieved. So you sometimes have to be relaxed in this situation. The most important thing that you don't increase the toxicity for your patient, and you try your best to minimize the pain. Those are the reference I used, and it's also good reference for you. The NCCN guidelines, the pain, adult cancer pain. It's a very good reference, detailed and actually advanced. Also, you can look into those two articles that I referenced here for more into managing the toxicity and guidelines for treatment. And thank you.
شكرا دكتورة نهى, الله يعطيك العافية يا رب. Please, if you have any question for Dr. Noha, type it please in the chat.
يعني شكرا لكم كلكم بصراحة على الحضور، يعني أتمنى أنكم فعلا تستفيدوا. شكله الموضوع سهل ما في أسئلة.
شكرا لك دكتورة نهى وشكرا جميعا على الحضور. إن شاء الله بكرة السوليد تيومر حنبدأ إن شاء الله الساعة 8 مساء. شكرا الله يعطيكم العافية. شكرا دكتورة.
ايوه السلايد ايناس انا بعثت لك اياها، تقدري تعملي لها شير مع اللي يحتاجها يعني. تمام
إن شاء الله. تمام.
شكرا لكم.
شكرا.